Good evening everyone, and thanks Ashish sir and Vijay sir for giving me this opportunity. Today we will have a small talk on mechanisms of resistance in IO. So the flow of presentation will be the introduction followed by the types of resistance, the definitions of the different types of resistance, factors that contribute to resistance, the pathways of primary and secondary resistance, and some words on classic oncologic pathways leading to resistance, and the conclusion of the take-home messages. So what we see that cancer immunotherapy can induce long-lasting responses in patients with metastatic cancers in wide range of histologies, and broadening the clinical applicability of these treatments requires an improved understanding on the mechanisms that limits the use of cancer immunotherapy. The interactions between the immune system and the cancer cells are continuous, it's dynamic and evolving from the initial establishment of the cancer cell to the development of the metastatic disease, which is dependent on the immune invasion. So as the molecular mechanisms of resistance to immunotherapy is elucidated, actionable strategies to prevent or treat them may be derived to improve the clinical outcomes for the patients. So the focus of treatment has shifted from the tumor itself to the host's immune system to mobilize the immune cells and to recognize and eventually eliminate the cancer cells. So a hallmark of immunotherapy is the durability of response, most likely due to the memory of the adaptive immune system, which translates into long-term survivals. So the tumor microenvironment, the tumor immunogenicity, the antigen presentations, neoantigens, the classic oncologic pathways, these all play a role in response and resistance to immune checkpoint blockade. So the biggest challenge for cancer immunotherapy field is to understand the complex resistance mechanisms and to develop effective strategies, combination strategies to overcome this resistance. So next comes the types of resistance, the primary resistance, the adaptive resistance, and the secondary resistance. These are the three resistance which we have. The primary resistance, drug resistance, also known as the intrinsic resistance, represents a clinical situation in which the malignant tumor doesn't respond to the immunotherapy only. The incidence of primary resistance was as high as 60% in some cancer types, where the clinical response rate was very low. So the mechanistic basis of lack of response to immunotherapy may include the adaptive immune resistance also. So what's an adaptive immune resistance? The mechanism of resistance where a cancer is recognized by the immune system, but it protects itself by adapting to the immune attack. So given the evolving nature of the immune cell or cell interaction, this could clinically manifest as a primary resistance, it could manifest as a mixed response or as an acquired resistance. And acquired resistance is a resistance where the clinical situation in which a tumor can initially respond, followed by a relapse or progression after a certain period of time. So the intrinsic mechanism of resistance is in a tabular form, or the alteration of the signaling pathways, the lack of antigenic mutations, the dedifferentiations. I will explain them in detail. So intrinsic resistance is seen when cancer cells alter processes that are related to immune recognition, cell signaling, gene expression, and DNA damage response. So tumor immunogenicity, the ability of the tumor to induce an adaptive immune response, relies on the recognition of the tumor cancer cells as foreign and high tumor mutation burden with accompanying with elevated neoantigen expression. This plays an important role in the anti-tumor immunity. So the mechanisms that leads to neoantigen expression by cancer cells may lead to acquired resistance to immuno-oncologic agents. Another thing is immune editing, which suggests that constant interactions between the immune system and the cancer cells result in selection of subclones within the tumor that lack expression of neoantigens, subsequently which leads to poor immunogenicity and resistance to immuno-oncologic agents. So with increased intratumoral heterogeneity, there is a greater likelihood that a poorly immunogenic subclone could be selected, thus decreasing the sensitivity to checkpoint inhibitors. So the mechanisms of intrinsic resistance are lack of antigenic mutations, the loss of tumor antigen expression, the loss of HLA expressions, the alterations in the antigen processing machinery, the alterations of several signaling pathways like the MAP kinase, PIK3 kinase, WNT, and interferons, the constitutive PD-L1 expression, then intrinsic factors associated with acquired resistance of cancer, including loss of target antigen, HLA, and altered interferon signaling. So next comes the extrinsic mechanisms of resistance to immunotherapy. Mostly it's related with the tumor microenvironment, which has multiple cells. So extrinsic resistance occurs to external to the tumor cells throughout the T cell activation process. So tumor microenvironment, it plays a major role in that, and it consists of various extrinsic factors to the cancer cells, including the immune and the stromal cells, the vasculature, the extracellular matrix, the cytokines that influence the response to therapy. So immune suppressive cells along with inhibitory cytokines in the tumor microenvironment can undermine the anti-tumor response. Regulatory cells or Tregs are known to facilitate self-tolerance by suppressing the T effector function through inhibitory cytokines and direct contact, which limits the inflammation. Next, the myeloid-derived suppressor cells are another type of regulatory cells within the TME that can promote immune evasion and tumor growth. Tumor-associated macrophage, mostly the M2 macrophages, also promotes tumor progression through modifications of the TME. The cytokine milieu within the TME is involved in immune cell recruitment, activation and proliferation, exerting both immune stimulatory and suppressive effects. So several chemokines including the CCL5, CCL17, CCL22, CXCL8, these plays an important role in recruiting the MDSCs and the Tregs to the TME, thus promoting an immunosuppressive climate. TGF-beta is also another factor which signaling influences the multiple TME elements including cell growth and differentiation, wound healing, apoptosis and immune suppression. So TGF-beta also limits the immune suppression through inhibition of the CTLs while upregulating the Tregs. So elevated TGF-beta signaling was associated with poorly immunogenic tumors. So in addition to promoting angiogenesis, VEGF functions as an immunosuppressive cytokine and is also associated with resistance to immunotherapeutic agents. So overall, most of these factors in the tumor microenvironment, they might lead to immunosuppressive phenomena which leads to immune resistance. So in short, the CTLA, PD-L1 and other immune checkpoints, the T cell exhaustion, the immune suppressive cell populations, the cytokines and the metabolite release in the tumor microenvironment, all this leads to the extrinsic mechanisms of resistance in the immunotherapeutic agents. The factors for resistance: reduction in the quantity or quality of the anti-tumor T lymphocytes, the tumor mutation burden and the adaptations, the downregulation of the loss of neoantigen expression, IDO expression, the loss of P10 expression, overexpression or gain of function mutations in the WNT and beta-catenin pathway. One slide on classic oncologic pathways. Through aberrations in the oncogenes and tumor suppression, oncologic signaling pathways can regulate the immune response. There are canonical pathways which influence the TME by altering the immune cell composition and cytokine profile, rendering the tumor cells resistant to ICB. Increased MAP kinase signaling impairs the recruitment and functions of TILs through expression of VEGF and multiple other inhibitory cytokines, resulting in immune evasion. So the loss of tumor suppressor P10 or the phosphatase angiotensin homologue results in constitutive activation of the PIK3 pathway leading to tumorigenesis. Additionally, P10 deletion was also shown to decrease the CTL activity through expression of VEGF and recruitment of inhibitory cells to the TME. Consequently, loss of P10 was associated with resistance to anti-PD-1 therapy. Abnormalities in the WNT beta-catenin signaling pathway has been observed in multiple tumor histologies and are also correlated with increased cell invasiveness and metastatic potential. IDO or indolemin 2,3 dioxygenase 1 is a rate-limiting enzyme that converts tryptophan to its metabolite kynurenine and has been associated with suppression of T effector function and resistance to ICB. So there are some other resistance mechanisms also. This is in tabular form in some PDL overexpressed tumor, non-reversible and T cell exhaustion, co-expression of other molecules in the PD-L1 and CTLA inhibitor combination therapies, also immunoediting and other factors, and high tumor overload burdens also. So two slides on this, monitoring resistance mechanisms. So baseline assessment of the tumor microenvironment typically involves the molecular analysis for mutational load and driver mutations. So longitudinal evaluation of fresh serial samples from tumor, blood and microbiome during the treatment allows for a deep analysis to unveil the potential mechanisms of this therapeutic resistance. So take-home messages is how to clinically address the resistance is more challenging. Identifying the missing link in the subgroup of patients might offer opportunity to provide what is missing, but this might be unattainable at an individual patient level. So bringing clinical benefit to the majority of the patient requires a complete understanding of the mechanisms that would lead to effective anti-tumor response and the different tumor cell intrinsic and extrinsic pathways which might lead to primary, secondary or acquired resistance to immunotherapy. So in future, to clarify targetable heterogeneous mechanisms of drug resistance, it is necessary to conduct sequential tumor biopsies and peripheral blood sampling of tumor patients during treatment and analyze comprehensively in combination with multiple factors to use new technologies. such as whole genome sequencing and single sequencing, so that we can characterize the drug resistance or the subsite of the clones. With this, I end my talk.